been declared a public health emergency of international concern. What is a public health emergency of international concern? It's an extraordinary event which is determined to constitute a public health risk to other states through the international spread of disease and potentially requires a coordinated international response. Monkeypox now is the 7th public health emergency of international concern since the IHR came into force. In 2001, we had H1N1, which was declared a public health emergency of international concern. In 2014, polio was declared, wild polio virus was declared a public health emergency of international concern. In the same year, the West Africa Ebola outbreak was declared a public health emergency of international concern. In 2016, Zika was declared a public health emergency of international concern. 2019, Ebola in the Democratic Republic of Congo was declared a public health emergency of international concern. And in 2020, the ongoing COVID pandemic was declared a public health emergency of international concern. And again, this year, monkeypox has been declared. So we really think that this really is important. And that's the categorization of the countries that is based on the temporary recommendations. Group 1, no history of monkeypox in the human population. Group 2, recently imported monkeypox cases. Group 3, zoonotic transmission. And Group 4, countries with manufacturing capacity for medical countermeasures. That's how the recommendations, temporary recommendations, were made that were issued by the DG after the advice of the emergency committee. What are the objectives of this webinar? We hope that it will support the continental response by advocating for proactive measures from African leaders to overcome monkeypox. 2, we hope that it will help establish an interaction between health workers, public health, and science for the elimination of monkeypox. And 3, that it will create awareness, knowledge, and sharing on skills, best practices, and lessons learned from the response to COVID-19 for monkeypox. We really have a high caliber panel. We've already had the keynote address. I've already told you the housekeeping, and we are going to have an overview of the description of monkeypox, diagnosis, treatment, and then we'll have a Q&A session. And then in the second part, we'll have surveillance and control, country perspectives with perspectives from Ghana and Central African Republic. And then we will look at how to mount an effective response, risk communication and community engagement, and then vaccines and immunization. And then we'll have a second Q&A session, and then concluding remarks. I would like now to invite my co-moderator, Professor Mohammed, to moderate the first session. Professor Mohammed, over to you. Professor, you need to unmute.
Sorry for that. Thank you very much, Dr. Ambrose, for this key housekeeping notes. This very important webinar on monkeypox will last about two hours. And we invited 8 speakers to share with you more recent data and knowledge on monkeypox. Our major challenge is to managing the time properly to keep sufficient space for discussion and debate. So I invite you to start typing your question in the chat. And also, I ask our speakers to respect the allocated time to keep more space for discussion after that. Now we can start with the first part of this webinar, and I will invite the first speakers, Dr. Tibel Traore. Dr. Tibel Traore is the One Health focal point for WHO Afro. He's a technical officer for preparedness at the Emergency preparedness and response clusters. And Dr. Tipo will talk about general overview, description, the monkeypox virus, the diseases it causes, mode of transmission, ecology, and geographical distribution. Dr. Traore, the floor is yours for 10 minutes.
Okay, thank you very much, Professor Mohammed, and I'm pleased to be here. I will just go through, before wasting time, I'll go through the general overview. You can see which part will be covered in this talk. I will talk about the virus. Oh, mine is in a movie. Okay, thank you. Thank you again. Sorry for this. The overview has been given in several documents and occasions as well. Recently, Dr. Talusna, who is with us, wrote a piece of article about the monkeypox, and you can that can be found in the Africa Health. It is just a recent publication, and if on your right, if you look carefully, you will see in red, managing epidemics. And this was published in 2018. Again, but we are living in 2022. So the information is there, the knowledge is there, and you can see the 10 steps which should be taken to address monkeypox, because if the knowledge is there and we comply to it, and certainly we would have reduced we would have mitigated the risk of this disease spreading. And originally it is such a zoonotic disease, but when it comes to population, now the spread, the uncontrolled spread, or whether you can call it a control, it doesn't matter. If it is spreading, that means human is transmitted to human. And that you will see that one in a minute. It's not new. And we know it is a DNA virus. And you can see Dr. Belinda Ehring will talk a little bit about that. You can see the antibody can be generated and the DNA can be extracted. And this has been well described in 1988 by Fener and colleague. You can see the book is available, and you can see as well on your left, on your far right, that's the disease was observed in monkey. So that's what you can see in the clinical sign. You can see the pistols and further data on this disease, you will know about it. Now, the DNA has been really mapped. So you can see the different group which have been already mapped in the past. And this study was done again early. And so you can find it in the book of Fener, but the study has been done in 1985. And the strain discovered in DRC, you can have them in Nigeria and West African country as well. And when you look at the panel, you will see all those DNA well mapped. So we know the structure of the DNA, and so it shouldn't be a problem at all. And the human infection, I will not elaborate more than what was said in the opening speech, but you can see a disease which started probably in a small remote area. Now it is a global issue, and it took 50 years almost to do that. But do not forget.
Dr. Traore?
Yes, sorry?
Sorry for interrupt you.
Can you hear me?
Yes, I hear you.
Oh,
could you please put your slide on slideshow mode?
Oh, I thought it was on the mode, sorry.
No.
Okay.
Not
I will do sorry. Okay,
sorry.
I'm just doing
Thank you.
that.
Thank you.
Okay, I will do that. Hide it. Okay, now, can you see?
Yes, it's okay.
Mode?
Thank you.
Okay,
Thank you.
Okay.
Thank you very much.
Okay. That's fine. So now, if you look carefully and the monkeypox in human, it has been detected because there was an intensified surveillance for smallpox. This is because that was the time when the book was about to close, the vaccination stopped for smallpox. So the collaboration was very intense, and there was compliance to it. And so for that reason, and it was detected as a suspected cases for smallpox, because you just need to provide the meal for healthcare worker in the community. You detect the disease, you get $50 bonus, and so it was detected. And so the same can be conducted even now. We can do that. Why not? It can be done. Okay, anyway. So look at the clinical picture.
Let's take a closer look at the progression of monkeypox infection in humans and the various symptoms that accompany each stage.
Okay, now.
As we can see from the slide, the typical course of illness usually takes up to a month and can be divided into the following.
The reason I put this one, for you to be able to, for all of you to be able to go to the open WHO, and there is animation, there is a PowerPoint presentation. So this was there since 2019. And so the information is there, the knowledge is there. It's not new at all. And it can be improved. So for the transmission, for example, you can know if the rodent or the animals are the source of this infection. So a community education is crucial to that. And we cannot stop, certainly, the bushmeat eating or the contact with animals, but we can mitigate that risk. We can educate them so they know what to do. We know what to do. And the secondary infection, that's where it can take a different dimension. And now it's no more linear. It will be all over the place. That's the human-to-human infection where we are facing today. So you can even say there is infection of a pregnant woman, and it can go to the baby as well. The fetus, we have seen that one with Dr. Placide presented a similar case. And so Dr. Rosamond Lewis will talk about this, but you can see how the virus can spread. It can be spread through mucous membrane, and I underline etc. here because the eyes, the mouth, it is not all. Membrane, mucous membrane, you will see later in the presentation, it can go even sexual. And broken skin, even sexual. That's why I put other root and underline those ones. So body fluid, lesion, material, contaminated material and surface, all these can be can be a route really for the transmission. And so, but with education, we can reduce it. Otherwise, infection goes all over the place. And so, and we have seen this one, and surveillance data have shown it, and the risk was here already. The risk was present. And so these are the pattern we have seen in the last decade to now. And recently, and the global, you can see the global picture. Dr. Fiona introduced that one. I will not spend time on it because Dr. Charles will talk about it anyway. And you can see how the map, the global map is now, and where the blue, the dark blue, you can see the number of cases increase. It is over 100, and this is the legend. You can interpret, you can look at this by yourself. But what about those countries where data are no data? That means there is no monkeypox. Big question. And so we need to look at those data very carefully. But you will see in the presentation what will happen next. Okay. Now, so if you back to this, and you can see the global spread in 2022, and what could be the cause? What could be the risk factor for this one? Because in epidemiology, we know the risk factor. We can do something about it. even if we don't know the agent which caused the disease. And that's the general rule for epidemiology. The data as of 11 September, if you look at the case profile, now this is very interesting. And all among these, 5,000 over 5,970 are HIV positive, but they had monkeypox. But this column, well, it is unknown, and that's what they do and so and so. But this is very interesting picture because that does not involve only monkeypox, but it does mean even other sexually transmitted disease, which could be stopped if this patient had it, they will spread it. And so it is very important to know that and pay attention to this again. And men who have sex with men, that's okay, the majority, you can say it, but somewhere HIV positive, and it's just, we need to work together. We need to look at all this holistic. Going for monkeypox, you go for other disease. Going for HIV, go for other disease, so protection can be taken. Now, over the time and risk of communication, community engagement, and different various channels, probably this number is declining, but slowly declining. Because you can see the confidence interval, and it is getting narrow somewhere, it is getting wider as well. But again, we could have done a lot and to stop this disease spreading at that speed. Maybe in the later, we will do that. Now, so look at Africa. Africa is not exempt. And for a few countries, we have other country, and the infection is not finished yet. So why it is not finished yet? What could we do to stop this? Is it just publishing, or is just we need to engage the community to tackle other disease at the same time with monkeypox? Or what else needs to be done? It is, you will see 8, 9, 10, it's not much, but infection will spread always from infectious cases. So I mean, it is there. And so these are the map which my colleague from the health information shared this morning, and I thank them for updating. Okay, so that's the AP curve you can see, but when you look at this, you will see, okay, as we progress, disease progress, there is a reduction, of course, on this latest week. That's whether data were reported or not. How is the surveillance? Dr. Charles Okot will talk about this. But more data are collected and more laboratory confirmation data are received, then this data, it can be used to take serious decision and to stop this disease in the coming weeks or months. Now,
Dr. Africa,
yes, okay.
Could you please conclude?
Okay, thank you very much. I will. So you have seen the pattern, the global pattern, but in Africa, when you look at it, you see the pyramid for sex, age, and distribution. I will conclude quickly, but again, look at this picture and look at the recent publication made by Aguena, and I think this is very important part, because when you look at how disease is transmitted and the symptomatic, for example, in the literature, you will say rash is developed, then you start transmitting. But this data shows, yes, but it can be transmitted without rash, pre-rash, and even after rash. And I will give you the reference for this paper. You can look at it, but this was done in Nigeria, and where sex transmission is documented. Okay, here is for that means if these are the HIV, they will spread it. They had the gonorrhea, they will spread it as well. Please pay attention to this and tackle disease. This is the paper. Okay, now you can go here daily and find out where Africa data for African region. Okay, now to tackle monkeypox, you need to know what's going in the wildlife, what is going in human population. One sector cannot do this. We need to work together, and we need to have trust, community engagement, community participation, all are part of it. That Dr. Julian with us will talk about, will address it if question comes. The trust, culture, knowledge, all are very important. So you have some resources here for One Health approach, which we talk about, and to address this kind of disease and other zoonotic diseases. I'll stop here with all this. Thank you, and just time. Thank you very much. Over to you.
Thank you,
Professor Mohamed.
Thank you very much, Dr. Traore, for this very interesting presentation. So we'll move to second presentation about diagnostic test and appropriate handling and shipment of biological specimens. And I will invite Dr. Belinda Herring for this presentation. Dr. Herring is a virologist at the WHO Regional Office for Africa in Brazzaville, Congo. Dr. Herring is the laboratory focal point for outbreak response in the emergency preparedness and response team. Dr. Herring, the floor is yours. You have 10 minutes, please.
Thank you very much, Dr. Chakron, and I will be brief. I have 2 slides, so we can move on when they're in presenter mode. Thank you very much. Next slide, please. So looking at laboratory diagnosis of monkeypox, we first need to consider what kind of specimen to collect. And so generally, the best specimen is fluid from a skin lesion, and this would be taken by a swab or swab. So the vesicle fluid that you see in a monkeypox lesion is basically a big packet of virus. So the other specimen that is good to collect is the roof from one of the lesions or a lesion crust. Now, when you're looking at patients with monkeypox or suggested monkeypox, there are a number of other diseases that also cause lesions like this. So if we consider varicella zoster, which can be either present as chickenpox or shingles, the lesions that are presented are very similar. So they're vesicles basically filled with virus, and then the scabs crust over. Some other diseases that may also present like this are the enteroviruses in children, hand, foot, and mouth disease, and musculum contagiosum. There's other herpes viruses that may present like this, measles, scabies, syphilis, bacterial disease. So it's important to have, look at the lesions and then also consider other possible diseases. But certainly the specimen that you need to collect is the fluid from the lesion on a swab to do diagnosis. So the recommended methods for monkeypox detection is PCR. So if you have access to real-time PCR, which I think most laboratories do, it would be real-time PCR with monkeypox virus primers, or you may have clade-specific primers, but monkeypox primers are adequate to detect monkeypox. There are a number of available detection kits in the marketplace for monkeypox detection. And this is only a small list of what is available, because there's probably more players that have come into the marketplace since it was identified as a public health emergency of international concern. When you do choose a kit that you would like to use, it's important that you validate it in your laboratory first. And positive controls are available from various standards agencies if you need positive controls. At WHO, following a desk review, we identified 2 potential kits for procurement for countries in the African region, the Life River Monkeypox PCR kit and the TIB Mobile Monkeypox kit. So both of these kits, or the countries have had a choice, have been procured for every country in the African region. It's good to note that these are not emergency use listed by WHO, and they're not necessarily endorsed by WHO. They have been recommended following a desk review of available reagents at the time when we were doing procurement. But there are other kits available. So there's the RADI monkeypox detection kit, which is being used in Democratic Republic of Congo, and it has been validated by INRB. There's the Bioprofectus monkeypox virus kit. This has been validated by NCDC, or the Nigeria Center for Disease Control, and it has been distributed by Africa CDC as part of their training program in the region. So other partners have also delivered training on monkeypox PCR. So we've had trainings from Africa CDC and WAHO in the region, both in West Africa and East Africa. And some of these kits are also being validated by other laboratories. With that said, most current samples that are being detected, and this includes on a global scale, belong to clade 2B, which is the current clade that is present in North America and Europe. And that's clade 2B is a sublineage of clade 2. And Dr. Emmanuel will talk more about this in a subsequent talk. Next slide, please. So when we're thinking about transporting our specimens, we need to think about how they're being transported, whether it's going to be nationally within your country or internationally, and what mode of transport. Anything that is transported by air needs to be transported under IATA regulations. And so with IATA regulations, monkeypox specimens, even if they're patient specimens, need to be shipped as category A infectious substances. So that's UN number 2814. And so this category has special shipping requirements. And one of them is particular packaging, which you can see there in blue. So category A packaging, which is P620. And of course, when you're shipping specimens, they should all be triple packaged. One of the other requirements for shipping by air, category A specimens, is that you need to have somebody who can complete and sign a dangerous goods declaration, because this must accompany, or the specimens must be shipped with a dangerous goods declaration. So you may have people in your country who are IATA certified to ship infectious substances. If you're shipping nationally and shipping by road, you can use, all you need to do is make sure that it is triple packaged, and it's obviously packaged in a safe manner so that neither the shipper or the receiver will be exposed to the pathogen during the transport or the reception of the goods. So I've just listed up there the recommended specimens, and so they need to be shipped in sealed containers. I've also put down on the bottom the infectious substance shipping guidance document from WHO. And if you have individuals in your country who've previously done a course with WHO on infectious substance shipping, they can do a refresher course, and that's available through the Health Security Learning Platform. Thank you very much, Chair, Professor Chakram. And that concludes my presentation. I'm happy to answer any questions in the chat or afterwards. Over.
Thank you very much, Dr. Herring, for this short and very interesting presentation. So we will move to the third and last presentation of this first part of the webinar, is about clinical care of patient and infection prevention and control. And I will invite Dr. Rosamond Lewis. Dr. Rosamond Lewis is the WHO technical lead for monkeypox and heads of the smallpox secretariat of the WHO Health Emergencies Program at WHO headquarters in Geneva, leading on emergency preparedness of orthopox viruses for the agency. Dr. Lewis, the floor is yours.
Good morning, good afternoon, good evening. Thank you very much for the opportunity to be here with you today. So we're going to talk, as you just mentioned, about case presentation, clinical care, and infection prevention and control. Just to be sure. Yeah, okay. So on this slide here, we show some of the basic symptoms. So fever, swollen lymph nodes, which can be in the neck, inguinal area, anywhere, a typical or not typical rash, sores in the mouth or throat, irritation of the eyes, and involvement of the skin and the mucous membranes of the genitals or perineum, skin, genital, or rectal pain. And monkeypox treatment remains mostly supportive and symptomatic, and we can talk a little bit about other forms of treatment. There is specific antiviral treatment known as tecovirimat. It is currently available to countries under study protocols, such as a randomized controlled trial or a monitoring emergency use of unregistered interventions. So basically, both methods through which we can collect standard data so that we can also learn from the deployment of countermeasures. I'm trying to move to my next slide. Okay. Yep. Sorry, my computer seems to be reacting slowly. So how is monkeypox being transmitted currently? You've heard that, of course, we've known about monkeypox for the virus 70 years, the disease 50 years, and then suddenly in May of this year, we began to see a sudden unexpected outbreak that you've heard about, now affecting more than 100 countries, approaching 60,000 cases and 22 deaths among confirmed cases. And so therefore, in this new context, the knowledge of transmission is obviously evolving. So we know about zoonotic transmission from live or dead animals in usually a remote sylvatic forested setting. But now we're learning more and more about person-to-person contact, which is, of course, already described in the household setting with small outbreaks that didn't really last for very long or extend very far. But with the dropping of smallpox vaccine around the world 40 years ago, with smallpox eradication, we have a much larger susceptible population. Basically, the whole world is now susceptible to orthopox viruses, of which monkeypox is one. So now that we have a susceptible population, person-to-person contact represents a higher risk than it did before when people were vaccinated, more people were vaccinated. So what we're learning now is that sexual encounters are in fact the most commonly reported form of or modus, sort of context in which transmission has occurred or has been reported by persons themselves. And they have reported transmission between men, so men who have sex with men, as Fiona outlined, gay, bisexual, or otherwise, but also between men and women. And we're seeing, you've seen the demographics in some countries are quite different from other countries. Some have 3/4 men, 1/4 women, or others have 98% men. So the epidemiology is different in different places. However, we are seeing that sexual transmission is transmission during sexual activity is really important. However, this can happen through many routes. So face-to-face, including talking, breathing, close proximity, sharing of respiratory secretions, skin-to-skin contact, touching, vaginal or anal sex, mouth-to-mouth contact, such as kissing, mouth-to-skin, such as oral sex, and transmission through sexual fluids is possible. We're learning more about this all the time. It's not yet confirmed, but very likely. Also through contaminated environments, such as surfaces, objects, and materials such as bedding, towels, has actually been shown to occur. Not very often, but it has been shown to occur in health workers. And so that's an important feature. And then common exposure settings include parties, bars, saunas. But the concern is not so much the setting itself as activities that may occur in conjunction with these settings, such as the activities that we've just talked about. So what do we know about HIV and monkeypox? So what we know is that among cases with known HIV status, as Thieble has shown you, about 40% are HIV positive. However, this is partial information. There are similar risk factors for HIV as there are for exposure to monkeypox, which is sexual activity, for example, not the only risk factor, but one. And there are no, so far, apparent clinical implications for well-controlled HIV infection. So for this particular situation, it's really important that if monkeypox is suspected, that the patient should also be assessed and tested for other sexually transmitted infections or other infections altogether, but also especially and including previously undiagnosed HIV or inadequately controlled HIV. Because among severe and fatal cases, compromised immunity is often present. So people who have uncontrolled HIV infection are definitely at higher risk of severe disease and possibly death. We have seen this in the African setting before this outbreak. Nigeria has reported this finding in the past already since the outbreak began there in 2017. And we are now seeing this in other parts of the world as well. So untreated HIV infection is definitely a risk for severe disease. What we don't really know yet is the relationship between HIV infection and immune response. How does HIV infection, how does that affect antibody cell mediated immunity in response to monkeypox? We don't know this. And we also don't know much about the interactions between antiretrovirals and possible treatments, HIV antiretrovirals and possible treatments for monkeypox, such as tecovirimat. So the complications, you've heard about them, you've seen them, bacterial infection, diarrhea and vomiting. The important thing is ability to continue swallowing, eating, drinking. Otherwise, you may have abscesses develop with airway obstruction. We've heard about encephalitis. We've heard of a few deaths in persons with encephalitis. This has always been described, and we are again seeing it now that we have more cases around the world. Sepsis has also been reported in the past and in the current outbreak. What is new in terms of complications are involvement of the urethra and the rectum, leading to urinary retention, urethritis, and proctitis. And this is obviously something new, and we're learning how to cope and manage with those presentations. You have a list of danger signs there. I would add to that extreme pain, because pain is one of the reasons for hospitalization. Okay, it looks like my computer wants me to hit next twice. Sorry. So long-term sequelae, essentially what we've talked about due to complications, but that includes skin complications, as you're seeing here. A very sad situation with swelling and sloughing off of the skin, but also ultimately when there is full recovery, it can also leave some depigmentation. Involvement of the eyes can lead to corneal ulcers and blindness. And of course, we know about the complications during pregnancy, which include miscarriage, fetal loss, stillbirth. And these are obviously means that someone who is pregnant is at risk of complications and needs to be monitored very carefully. So we are recommending optimized supportive care in all contexts in the world. And these are some of the other features. So when we're taking care of a patient with monkeypox, we're looking at fever management, pain management, very close care of the skin, eyes, and mouth, because this is where the serious complications can also arise. Respiratory care where needed. It doesn't seem to be a major feature right now. Hydration and nutritional support, of course, mental health support, including prevention of stigma and discrimination or support where that is occurring, prevention and treatment of complications, and testing and treatment for other infections that we've already mentioned. So we'll skip over this. We've talked about fever and pain management. And management skin care. So persons should be advised to avoid touching or scratching lesions. They can also self-inoculate their own eyes, for example, by touching their own lesions, keeping clean and dry, protecting and hydrating with moist dressings, prevention and care for opportunistic fungal infections, for example, and treating, of course, inguinal ulcers or genital ulcers. Sometimes abscesses need to be drained. Lesions in the mouth need to be taken care of because they're painful, but also because they can prevent someone from eating or drinking. And so if it's in a child in the African setting, you also want to consider vitamin A, because obviously that can help prevent blindness in children who may be having some vitamin A deficiency. The sores in the mouth are also a prominent source of infection, of course, through respiratory droplets or exposure to respiratory secretions. So here's some of the examples from our colleagues, Dr. Ogoina and Dr. Mbala, who kindly provided photographs to show how complications can arise. I think one of the considerations that we worry about or wonder about is breastfeeding. So it depends, of course, whether it's possible to offer alternatives to breastfeeding. We don't know if there's any virus in the breast milk, and if the infant has does not have a good access to alternatives, then it's most important is to make sure that the patient, the infant, is well looked after and well nourished. So breastfeeding can continue, but in that situation, we also recommend that the mother make sure to wash hands before and after breastfeeding, wear a mask, both to protect the infant from the mother, or in the other way around, maybe it's the mother that or the caregiver that needs to be protected from a child who may have monkeypox. We've mentioned the importance of avoiding and preventing stigma and discrimination. This seems to be a feature of monkeypox, regardless of the setting and regardless of the group in which it is. We've heard for a long time that there is concern and shame related to monkeypox. There's no real reason that this should be the case. We are now seeing this global outbreak concern about discrimination because someone has traveled from a certain location or because someone belongs to a certain population group. And so it's critically important to offer public health programs that are based on knowledge, based on fact, and based on supportive care and emotional support to persons who are affected. I won't go through this table with you, but it's to show you that for each condition, clinical condition in column 1, you have a clear treatment objective outlined in column 2. You can look at these slides afterwards, treatment and care suggestions, and of course, modes of monitoring. For infection prevention and control, obviously we recommend isolation, whether in the health facility or at home. And in the health facility, we do recommend that health workers protect themselves with personal protective equipment, which would include gown, mask, goggles, and gloves to ensure full and appropriate cleaning and disinfection and safe waste management and safe handling of linens, as these are all fomites that could perhaps lead to infection of someone else. At home, it's important to provide a separate area for the patient if possible and to minimize contact and to use, of course, while providing care. So it's obviously challenging if the person is at home. They should look after themselves as much as they can if it's an adult and live alone for that duration if they can. Otherwise, we have these other recommendations of also protecting oneself as a caregiver while caring for the patient and while taking care of linen, and also likewise to disinfect surfaces and floors and wash hands frequently. So this is the WHO guidance that has been published in June of this year, 2022. You'll see that there's a chapter for every possible need at the moment. This is early days in terms of WHO interim guidance, and this development process is ongoing. There will be a revision coming out probably in a couple of months based on emerging evidence from research, but you can see that here we cover all the chapters of mild or uncomplicated patients, mental health care of patients, caring for women during and after pregnancy, consideration for sexually active groups, and so on. So this is a full guide, but as the evidence evolves, the guide will be updated. It's available on the WHO website. And on the WHO website, there's also a clinical platform available where clinicians and health authorities can input detailed case data, which is really, really super important and valuable for supporting our learning, our joint collective learning exercise. Anyone, a clinician can access this, for example, and input data. It's all anonymized, so you don't need to worry about confidentiality. And if ministries of health can support this exercise, we will all learn more together about how monkeypox is evolving now in the world. These are some of the resources you have access to. There are many more on the WHO website, and I thank you all for your attention.
Thank you very much.
Bye.
Thank you very much, Dr. Rosamond, for a very, very interesting presentation. And I would like to thanks all speakers of this first part of webinar. And thank you also for speakers who started to answer for some question in the chat. So we don't have enough time, but we will take 2 or 3 questions before moving to the next part of this webinar. The first question is about the severity of numbers of lesions versus mortality in Africa. Dr. Traore or Dr. Rosamond, could you please answer to this question?
Dr. Traore, would you like, sorry, can you repeat the question?
Yeah, you can. The question is about the severity of numbers of lesion versus mortality in Africa. Please go ahead.
Sure,
Okay.
sure. I'm happy to take that. From what we've learned from monkeypox in the African setting over since of course 1970, and the many studies that were done in the 1980s at the end of the smallpox eradication era to learn more about monkeypox and the public health risk that it represented at that time. Remember, this was 45 years ago. And so at that time, it was clearly demonstrated. Most of the work was done in the Democratic Republic of the Congo. So most of the work relates to clade 1, the former Congo Basin clade is now known as clade 1. And so again, we have to distinguish the two separate clades, and what we were learning about both of these clades may evolve. But certainly the research at the time it clearly illustrated that children, often children with many more lesions, were at much higher risk for severe complications and death.
Okay, thank you. The second question is about the transmission of the virus, and it is well known now that the transmission modality is through contact, but why it is high in MSM than other?
I think viruses do what we all do, which is we try to survive, right? We try to survive and we try to multiply when we can. And viruses looking always for environments where they can thrive. And so what it seems to have happened is that for different reasons, the facility of the virus moving from person to person through human to human transmission has increased over time. I mentioned earlier that one of those features is because we're no longer vaccinated against smallpox. So that's one reason. The other reason is encroachment on forest populations. More people are exposed perhaps to zoonotic transmission. But when it comes to human transmission, we are now seeing that there is sexual transmission. And by sexual transmission, I mean actual through sexual activity. So it is face-to-face contact. It's skin-to-skin contact, and there may be transmission through sexual body fluids, which we don't know yet for sure. However, it's the frequency of the contact and the opportunities the virus finds. So there are population groups that have more sexual partners than others. They may be men, they may be women, they may be sex workers, they may be doing it for a living, or they may be doing it, participating in activities that are social activities. Whatever the context, approaching this from a non-judgmental public health approach and identifying that it is the frequency of the contact that allows the virus to spread more rapidly from one person to another. And hence, WHO has issued the recommendations of wherever possible at this time during the outbreak, reducing the number of sexual partners, avoiding, if possible, casual sex, casual contacts, one-time contacts to reduce the risk of being exposed to the virus and not giving the virus that opportunity to spread from one person to another.
Can we confirm now the sexual transmission and that the virus is present in the semen?
I'm happy to take these questions, but there are other panelists here who may want to also participate.
Okay. If another, yes, Dr. Traore, please go ahead.
Yes, I can start then. Dr. Rosamond and colleague can complete it. And
Yes.
based on the literature and based on the data just presented in from Nigeria, of course, it is a small study, but it requires, again, we are all required to conduct more studies to find out. I think with the global program, WHO program and partners, WHO and partner, there will be more research to be done on this area. And but if, for example, just you take an example of what was shown, and a sex worker which doesn't use a condom or have a multiple partner get infected, obviously, that person during the contact, skin to skin, mucus to mucus, will transmit the infection. That's because infection are always transmitted in various ways. And the study which was published about the sperm, the PCR positive sperm, we have seen that one. So that means the virus can be in the sex secretion. Now, what we need to encourage people, And all the researcher to do is to do more work like the preliminary work which were done in the 70s. You have seen how the research were intensified to find the genome and how the virus is. And the same thing needs to be conducted. We don't need to stop here. We can continue, and virus can be cultured. We need to do that. Because if you find it in PCR in super, yeah, so just to demonstrate it, culture it, but people will always discuss those results. It could be contamination. There are a lot of speculation about it, but more work needs to be done. But for the epidemiological point of view, what we have seen so far, there is a possibility for sexual transmission, but it does not mean monkeypox is a classic sexual transmitted disease like gonorrhea. So that's a big question. Okay, thank you very much. Over to you.
Thank you, Dr. Traoré. Thank you very much. Last question is, what is the regional capacities in testing the infection? Are all member states able to test for the virus within the country? If not, which labs can test and confirm the virus in the WHO Afro region? I think this question is for Dr. Belinda.
Yes, thank you. And I've answered the question in the chat, but I will also answer it here. So at present, all countries are being supported with testing reagents for monkeypox virus. So all countries have been PCR reagents have been procured, and around 50% of the countries have received their reagents now. So the reagents may go to the National Public Health Lab, or if there's a specific institute in your country that does public health testing, they may have gone there. So within the region, there is also an emerging dangerous pathogen laboratory network. And this is a network of around 13 laboratories within the region. So they have been supplied with extra testing materials so that they can be referral labs for countries that don't have testing reagents. So these are the ones that have agreed to test for other countries, the National Institute for Communicable Diseases in South Africa, Institute Pasteur in Dakar, and Institute Pasteur in Bangui. So that's in Senegal and the Central African Republic. Centre Pasteur Cameroon, which is obviously in Cameroon, and the Uganda Virus Research Institute, which is in Tebi in Uganda. If there are people on the call who need to ship specimens, I'd encourage you to get in touch with us, because there is a shipping mechanism by which countries can ship their specimens to these identified locations. And so please get in touch with us, or also your national lab, to let them know that you have specimens that you want tested. With regards, another question was with regards to storage. If you store the specimens at 4 to 8 degrees for 24 to 48 hours, if they're going to be stored prior to shipping, then they need to be stored at it's preferable to store them at minus 80 degrees. However, this is what we're dealing with here is a DNA virus. And as we know, you can get DNA from dinosaurs and dinosaur bones. So it's fairly robust and way more robust than some of the other viruses that we have seen, such as SARS-CoV-2 and EBD. So it's a fairly robust sample. So, and the organism does not need to be alive. The virus doesn't need to be alive or viable for testing with PCR. So thank you. Over.
Thank you very much. I think we will stop there. I will hand over to Dr. Ambrose for the second part, and I encourage all speakers to continue answering questions in the chat. And thank you very much for the very interesting first part of this webinar. Dr. Ambrose, the floor is yours.
Thank you very much, Mohammed, for this first part of the webinar. Now we go to the second part of the webinar, which has 6 interesting presentations. And for this session, I'm really kindly requesting Tiebli to help to summarize the questions that will be asked in French, and Bukare to help summarize the questions that will be asked in the chat room. in Portuguese. Now let's just go quickly to the first presentation, which is about surveillance and control. And this is being presented by Dr. Charles Okot, who is an epidemiologist with over 15 years experience and expertise in field epidemiology, epidemic preparedness and response in complex emergencies. Charles, over to you, please. Charles, I can't hear you. Are you muted?
Thank you, Ambrose. Sorry, I was muted. Good morning, good afternoon, good evening, all of you, wherever you are. I'm very pleased to share with you a short presentation on the overview of monkeypox surveillance. That is the outline of the presentation. Let me go straight to the presentation. Let's start by looking at the goal and objectives of monkeypox surveillance. And the goal is really to stop human-to-human transmission and ultimately stop the outbreak. And specifically, the objectives of monkeypox surveillance are to rapidly identify cases and clusters in order to provide optimal clinical care. We would like to isolate cases to prevent further transmission. We want to identify, manage, and follow up contacts to recognize early signs of disease and to identify risk groups for infection, but also risk groups for severe disease. We want to protect frontline health workers. And lastly, the objective is to tailor effective control and prevention measures. So what are the major components of monkeypox surveillance? They are basically case detection and reporting, an alert management system, case investigation or epidemiological investigation, contact tracing, data management, and lastly, reporting and documentation, which is something we always forget. Let's start with the first one, monkeypox case detection. This is aimed to facilitate early identification of suspected probable cases, of course, using the indicator and event-based surveillance. All these are part of the IDSR framework that is being implemented in the African region. And case detection is primarily based on the proper application of standard case definitions. And these standard case definitions should be widely disseminated to all our health facilities at community level, at points of entry, but also some other points of care, for example, in pharmacies, where patients are likely to report. Therefore, we need to sensitize our clinicians and community health workers to be on the alert for signs and symptoms of monkeypox. And we also need to inform communities to recognize early disease and inform them where and how to report. And in the healthcare facilities and all the reporting units, suspected cases should be immediately reported to the next level such that appropriate actions are taken. So case detection is really the starting point for our surveillance, and we need to improve that by alerting our healthcare workers and the community. The second aspect of surveillance is really an alert management. This is aimed to systematically manage and monitor alerts and reported cases. So we need to ensure that we have a functional alert management system in the country at national level, but also at lower level, at subnational level. This is to receive signals, reports of monkeypox cases. And all these alerts, rumors, and reports should be promptly verified and validated. And validated information needs to be referred for proper investigation and follow-up. It is of no point to set up an alert management system, then reported cases are not followed and they remain in the community. After several days, we get reports that several cases have not yet been followed. That is not the intention of having an alert management system. This is an algorithm showing how an alert management system is structured. I don't want to go through. You can look at this at a later time. The third aspect of monkeypox surveillance is actually case investigation or epidemiological investigation. This is very critical, and I want to note at this stage that in many African countries, we have not dedicated ample time to conduct detailed epidemiological investigation. That is why in many countries, we cannot actually properly describe the transmission pattern that is going on in the country. So we need to invest resources in case investigation. And this is aimed to elicit the source of infection, the mode of transmission and the transmission pattern, exposure factors, at-risk groups, and some of these other epidemiological parameters. So we need to conduct case investigation of all reported cases, and we mean all reported cases. You interview patients, caregivers, and healthcare workers, conduct clinical assessment of the patient, then you use a tool, the case reporting tool. Alternatively, and better actually, you need to use the case investigation form, because the case investigation form is more detailed and is going to gather more information for you to understand the dynamics of the outbreak. We need to carry out exposure investigations. We track all the activities of the patient in the last 21 days prior to symptom onset. And you realize that this is so elaborate. We need to formulate plausible hypotheses. How can we explain the transmission that is going on in the country? So as epidemiologists, we need to, after our investigation, come back with some plausible hypotheses. Of course, a line list is an important tool that we need to construct in every country and collect information from all reporting healthcare facilities. Definitely in the course of our case investigation, we need to conduct active case search to identify additional cases in the communities, but also in healthcare facilities. The case investigation is actually linked to contact tracing, which is aimed to interrupt transmission chain and facilitate early healthcare, especially for people who are at risk of severe disease. So we need to ensure that we set up a functional contact tracing system in the country at national and subnational levels, where we interview cases and identify and list all contacts, notify contacts within 24 hours of identification, and we monitor these contacts. We need to note that in the case of monkeypox, quarantine and exclusion from work is not necessary for contacts that are asymptomatic. I think this is important. Lastly, we need to set up a robust data management system. And this is constituted by epidemiologists, surveillance officers, data managers, and other cadres. We ensure that all data collection and reporting tools are disseminated to all levels, and we establish monkeypox database and collect reports from all reporting facilities. And we need to choose appropriate electronic tool to manage our data. Currently, as WHO, we recommend the adoption of Go Data, but this is not the only tool. You can use any other tool that you think is appropriate. And with this tool, you can conduct epidemiological analysis to describe and characterize the outbreak in terms of person, time, and place. These are basic epidemiology that we need to be that we need to be undertaking. Lastly, finally, we need to embark on reporting and documentation. This is really lacking. Countries need to prepare situation report and disseminate with the WHO and other stakeholders, because we need to know what is going on in the country. In addition, WHO also requires that every probable or confirmed case, countries should fill the case report form and share with the WHO. In addition to this, we need to get updated and consolidated line lists from countries, because this enables us to do detailed epidemiological analysis and understand the outbreak that is going on in the African region. Certainly, we need to get case or outbreak investigation reports that are written by country. And lastly, countries also on a periodic basis need to write detailed epidemiological reports and share with the WHO and other stakeholders. And lastly, to summarize the presentation, we need to note that effective surveillance is a prerequisite for early case detection, interrupting transmission chain, and eventually controlling the outbreak. Community participation and engagement is essential if we are to succeed in implementing our surveillance. Definitely, involvement of the private sector is paramount, because many of the cases that we are getting are high-profile people or travelers, and their first point of care is likely in the private sector. So we need to involve the private sector in our surveillance. And lastly, we need strong field epidemiology practice if we are to understand the dynamics and control the outbreak that is going on in the African continent. These are just tools that are put for your reference. We have surveillance, case investigation, and contact tracing interim guidance that has been revised lately on the 25th of August. You can get the link there. WHO also has an outbreak toolbox where you get all resources that can help you in setting up your surveillance system, but also responding to any outbreak. And lastly, this is a link to the reporting tool that WHO has shared with the country. It is a case reporting form that should be completed for each and every probable and confirmed case and shared with WHO. Thank you very much for listening. Over to you, Ambrose.
Thank you very much, Dr. Cott. Dr. Cott, please be looking in the Q&A, because there are some questions with respect to your presentation, which you could actually respond to the people who are raising them without us doing the Q&A. Now we're going to move to the next presentation, and this really for me an exciting one, which is country perspectives. And our first presenter is from Ghana, and is Dr. Henry Ajewi Nagai, who is the Chief of Party for JSI in charge of the PEPFAR-funded USAID Strengthening the Care Continuum and Global VAX projects implemented by the JSI in Ghana. He's a medical doctor and a public health development practitioner with over 23 years experience. Over to you, Henry.
Thank you very much, Ambrose, and good evening, afternoon, and morning to everybody listening and watching. It's a privilege to be here, and I present perspectives of monkeypox from Ghana from two approaches. One is concerning the current status of affairs in terms of monkeypox in the country, and also looking at some programmatic perspectives as it relates to a large-scale PEPFAR program, HIV program that I happen to be leading in the country. So as of September 6, the 84 confirmed cases of monkeypox have been recorded in the country. We also have about 535 suspected cases. 12 out of 16 regions have confirmed cases. And we have highest numbers in the region that have the capital, that is the Greater Accra region. We have recorded 4 deaths, and these deaths are both in the northern and the southern sectors. 38 districts have actually confirmed cases. One key important message is that no new region with confirmed cases since August 24, especially if I should use our September 6 information. The national case fatality rate is 4.8%. Looking at the age distribution, you can see clearly that the age 16 to 39 are those that are infected, and we have more male involvement than female. This gives us the distribution of monkeypox by region. And clearly, you can see where we're getting more confirmed cases are in the Greater Accra region. This is the region that has the capital of Ghana, Accra, and has a high population or density. We also have cases in the confirmed cases in the Ashanti region, which is described as the cultural capital of Ghana, also very high in terms of population. We have recorded 4 deaths, as I earlier on mentioned. When you look at the epic curve, it clearly identified the timing of the various spikes, as you can see, and we continue to monitor this in country. And as I speak, new data is coming through that is being analyzed by our public health division to look critically at even the population between 16 and 34 and drill down to provide further information that can help the response in country. Distribution of confirmed monkeypox cases, and I would like you to focus mainly on this that we have at September 6th. And you can see that all the regions in the country that have dotted boundaries and grayish have all confirmed cases. So cases have been confirmed in the northern part of Ghana, where socioeconomically is relatively deprived. Cases have been confirmed in the middle belt of the country, and also in the coastal areas. And the areas you see as deep red and light red, have 2 to 6, or the deep red ones have 7 or more cases. And you can see the pockets here, both in Upper West region here, and then we have these the western border that borders La Côte d'Ivoire, the Bono region, and then also on the coast here, south, where we have the capital, and we have a lot of the international airport is there. We have a lot of travel that comes through Accra. There are a couple of ideas that I want to share when it comes to our project that we continue to engage communities in the Western region, Western North and Ahafo regions of Ghana when it comes to monkeypox. This is because we implement a large-scale PEPFAR HIV program that responds to the needs of various key populations, including men who have sex with men, female sex workers, and other vulnerable populations and general populations. We, in interactions with one of our civil society organizations and members of the MSM community, there is this that we think all of us must take a critical look at. Previous speakers have mentioned it in various ways, but what we have identified is that we must be able to keep our current, what we call allyship with marginalized populations. This is where we listen as advocates to marginalized population, members of our MSM community, and have worked with these communities over years to respond to HIV, respond to other needs that they have. What we find is that this allyship is at risk at this moment. I have here direct quotations of some of the interviews that I happen to have conducted, that we conducted and got feedback. And quote, "They are at us again. What is this? It has been like this since I was born. People hate us until death. I'm a member of this community, that is the MSM community, and we meet here every day and have not seen anybody with that disease. This is based on the initial understandings, the evolving information about high prevalence of monkeypox in MSM communities outside the country. And the second quote, and it is named monkey disease, ABA. This is a typical Ghanaian expression. Now this government and the parliamentarians will have a reason even to arrest us when we meet. They had wanted to do this all the time. Why this name? That means, why this name at all? And this is in connection with the kind of stigma and the environment in which we have now in the country, where there is a private members bill through parliament that will have wide-ranging issues when it comes to MSM activities and programming that, as I speak, is currently stalled and not being discussed as it used to be. So there is a real threat to the allyship that has enabled various interventions, including that of HIV, to be successful. If we don't handle how we manage the information of monkeypox and connection to MSM community. There is also, from the various feedback, that there is need for the change of the name of the disease. WHO has had an open forum, and there has been redefinitions and classifications, as Melinda mentioned, where the West Africa and Central Africa strains that have been, we refer to them as clade 1 and 2, etc. But there's need to do more to look at the root of the name itself. The feedback indicates clearly, and we are aware, that the term monkey, as we know, and I think that we know that this has been reflected by MSM community, is anti-Black ethnicity expression and a slur language that is derogatory. And so I think, and the feedback that is keeping means that WHO must go further and look at the root of the name. It is not easy to do, as we know there are committees and scientific processes for doing this, but we know that monkeypox, as was described by Professor Traore, first identified in monkey and has long history of literature and everything else. But I think that we, together with WHO through the open forum, look at the name and explore how to change the name monkeypox, as it were. Communities feel the name is derogatory based on our interactions and will further stigmatize them. We are also very happy. WHO has released a new risk communication and community engagement guidelines, which will help further in the response. And one of the things that is coming out clearly is that low and middle income countries should not be left out of the Genius repurpose vaccines against monkeypox. We should not be at the last end of the queue. We must all together as one global community advocate and ensure that communities that need the vaccine are equally supported to have access as quickly as possible as more and more genuine doses become available. In Ghana, there has been development quickly of SBC materials, which you can see because of the polio issue in 2014, Ebola threat, we didn't have a case. And
Henry, you should be winding up.
Yes, marbles recently, we have kind of a robust surveillance system that is picking these things. These are some of them. There is a public health emergency operations center that is established by the government of the US in the region where I work. Just as an appreciation, let me thank the Ghana Health Service, the Director General, the Director of Public Health, Health Promotion, the Noguchi Memorial Institute of Medical Research, my team in Ghana and the US, and then the Maritime Precious Life Foundation and MSM organization and other CSOs that have provided the information. Thank you very much. Over, Ambrose.
Thank you very much, Henry. You raised a couple of issues. I really like the allyship, and it's a very interesting concept. So we will move to the other country perspective. And this is really being presented by none other than Mr. Emmanuel Nokune Yandoko, who is the Director of Research and Scientific Director of the Pasteur Institute in Bangui, and is a research professor at the University of Bangui in Central African Republic. He has worked extensively on the reserve of Ebola virus and demonstrated the first time in 1998 the genome of Ebola. Over to you, Emmanuel. Emmanuel, you have the floor. I can't hear you. Maybe you have not unmuted yourself.
Sorry. Yeah, sorry. Yeah. I want to thank the organizer of this webinar for invitation as a panelist. Since my slides are in English, I will present in French to feel comfortable. Let's switch to French. Donc, le monkeypox a été
Monkeypox was isolated for the first time in 1984 in Central African Republic, 4 years after eradicating smallpox. And so we had to wait until 2001 for the Pasteur Institute in Bangui for it to establish a biological diagnostic that allowed us to confirm the first case. And so the surveillance of monkeypox started in 2001 in Central African Republic. And it's only in 2018 that we started observing an increase of the number of cases per year, which pushed CAR to envisage One Health approach to health. And this is why we thought it was important to involve all the sectors to understand zoology, virology, ecology, epidemiology, and the anthropology of monkeypox. I will review these different aspects, these different approaches to show how we tackle monkeypox in CAR. Next slide, please. Next slide. Thank you. So at the epi level, please come back to the previous slide. Thank you, the map. Thank you. On the map, please. Thank you. As a previous speaker highlighted, in CAR, since 2001, we had 60 outbreaks, and they range from 1 case to 13 cases, and it can even go as far as infecting 25 people within an outbreak. We confirmed 107 cases in labs among 204 suspected cases. So this gives us a case fatality rate of 12 on 204 and not 12 on 160. So case fatality rate of 7.5% for monkeypox in CAR. And on the map that you see on the left, you see that the cases are concentrated in the southern part of CAR, and next to the border we have with the DRC and the Republic of Congo. Next slide, please. Next slide. We started developing new tools because the diagnostics we have. Next slide. Thank you. So the diagnostics are made only with the institute, the Pasteur Institute in Bangui. So in this multi-pronged fight, we have development of diagnostics. We use different tests, monoplex or multiplex, that we are using on the ground, on the field. And we are also developing cartridges that allow us to detect very quickly monkeypox. So these tools were developed by our colleagues from the Pasteur Institute in Shanghai. And for the serological aspect, it is our colleague Jean-Claude from Paris, from the Pasteur Institute, that helped us develop multiplex tests that are based on a library of more than 7,891 viral peptide representatives of the proteome of human pathogenic OPVX, and is also based on the multiplex assays based on 10 MPVX proteins and peptides. All these are being assessed at present. Next slide, please. Thank you. We're also developing tools to have a molecular characterizations of these viruses. The Shanghai team is developing a microfluidic technology and is generating droplets for targeted enrichments of droplets containing viral genome fragments. And there's also direct sequencing and in real time with the MinION on the ground. Next slide, please. Now, regarding zoology, the ecological niche of the virus, this virus, the genome of the virus, was identified in certain species, like the Fumsi cirrus. And we know that squirrels, the African squirrels, are very good candidates as reservoir of monkeypox. And a lot of studies have shown that there are antibodies in several species of squirrels. And so we believe that knowing these different types of monkeypox will allow us, will steer us towards the risk zones where monkeypox is going to manifest itself. Now, concerning zoology, next slide, please. The previous panelist referred to the importance of surveillance. Previous panelists had discussed the importance of surveillance on monkeypox cases, and this is what we're developing in CAR. When there's a confirmed case, we dispatch a mission on the ground with the lab team, the epi team, with veterinarian staff, and environment technicians. And during these missions, these survey missions, we attempt to identify the reservoir of the virus. So we try to find a rodent in that area to see if we can identify the presence of the virus. And we were able to collect, since 2019 up to 2020, 376 rodents. So there are squirrels, there are pangolins also that are reservoirs. These we conduct PCR tests and serological tests. I didn't put the results and the findings of these tests, but we were able to identify antibodies against monkeypox. And so if we extend the scope of this study, it will give us rich information on the reservoir of monkeypox in that area. Now, ecology. If we attempt to locate the different cases of outbreaks on the map, and so we add another layer with the climatic profile and deforestation. So all the data that we can add from environmental field we see that there's a link between the ecosystems and the occurrence of cases or of outbreaks. And there's also the more there is climate change, and the more mankind is present and next to these animals, the more we'll see cases of monkeypox in these regions. Next slide. Now, concerning anthropology, we started an anthropological investigation on monkeypox to try to understand what are the diagnoses, the treatments, and so we ask questions to healthcare workers, traditional healers, and also former patients to try to understand, because they don't all come to health centers, and this allows us to understand how the disease occurs and how it is being treated. We conduct investigations on local outbreaks. We try to understand the origins, why there was such an occurrence. Was there a contact with an animal in the week preceding the outbreak or the manifestation of the disease? We're trying to understand emergence factors and also the modes of transmission. Now, ethno-historical study. We try to understand the changes that occurred in the environment where there are cases, so wildlife, and the ecological context, but also the social changes that are linked to the emergence of monkeypox in CAR since 1970. Finally, at the ethno-ecological level, we try to understand perceptions and how wildlife is being observed and the current practices with wildlife. Is there a risk associated with the contact with wildlife? These are all the activities we are presently conducting. And as a panelist said a bit earlier, we benefit from the support of WHO Afro, and this helped us to validate the response plan against monkeypox epidemic. We established an endemic response team. We've reviewed and validated we distribute contact tracing tools, guidelines on MPX. All the guidelines from WHO are being domesticated in the country, and now there's a mission from WHO Afro that is planned for CAR that will help accompany the country to better manage these types of diseases and implement treatment, the vaccination protocol, and also develop awareness and community engagement tools, and continue and follow through the continued compassionate use of tecovirimat. I would like to thank you, and I thank all those that have supported the fight against monkeypox in CAR. Thank you very much. Thank you, Prof. Emmanuel.
And these are very valid points. We'll now move to the next presentation, which is from my colleague in Geneva, Peter Mala. Peter is currently the incident manager for the ongoing monkeypox outbreak at WHO headquarters level. He's an epidemiologist with extensive experience. Over to you, Peter.
Thank you, colleagues. I'm unmuting myself. So thank you, colleagues. I've just unmuted myself, so I hope you can hear me properly. So very quickly, I will go through this presentation by providing a framework. Allow me to present an overall framework of in addressing that question. How do you respond to monkeypox? So in this framework, I'm going to highlight two components. the details of which many of my colleagues have highlighted. The first component has to do with the supportive environment, the operational platform that makes the response possible. The other dimension is the technical components that comprises a number of technical elements that have been presented already. So the first thing, of course, as my colleague Okot ably demonstrated, you need to establish that you have an outbreak. Next slide, please. Once you've established that you have an outbreak, the next step, of course, is you investigate it to understand the dynamics of that outbreak within your country. And initially, you may not have the sort of picture you have before you, because this is a product of a number of weeks of months of data. At the very beginning, you might have very little information. So obviously, your risk assessment team in the form of the outbreak investigation team will need to go out there and look at the dynamics around the reported case or cases in order to come up with this important questions of how much of the disease do I have? Because that determines how you're going to respond. Where is this disease geographically? Because that informs your targeting. And who is affected in terms of all these details that are highlighted here. In the case of monkeypox, we seem to have this picture, and so far this picture is much more clearer for the so-called newly affected countries, mostly in Europe and in the Americas. As our colleague Okot mentioned, case investigation is still weak in the Afro region, so this picture is still incomplete. And if I may ask this question, why is case investigation a limitation in the region? So if that question can be answered, that could be very helpful going forward. Next, please. Now I'm going to talk about the two dimensions in the next point. Of course, the one dimension, as I mentioned, is this enabling environment or setup that will make it possible for the technical team to do their work. Let me take a minute to put a bit of history to this. Now that I'm in my third decade in WHO, I'm in the beginning of my third decade in the WHO doing this kind of work. Up to the mid-late 20s, the epidemiologist, myself or Okot or whoever, we were both part of the technical team and oftentimes would be responsible for coordinating the team as part of the so-called outbreak response team. And we lacked that supportive framework that would make the logistics we need possible, that would make the necessary coordination beyond the epidemiological unit or outbreak or public health or health unit possible. The financing and the planning, we lack that. I dare say, even in the broader international scheme of things, many of us would be sent to an affected country, and I've experienced that many times. And that this supportive framework would follow later. That's when we would do the SAF applications for funds. That's when the joint appeals would come in. And by the time the funds take shape, you already suffered for 3-4 weeks of trying to battle an outbreak with very little resources you need. And very quickly, let me speed up to the late, from 2018 going onward, when the global community came up with this incident management systems, countries establishing EOCs and so on. This has helped a lot. And this is what I'm talking about. So you need this leadership coordination mechanism framework, whatever you call it. You may call it incident management system, supported by EOCs and all of that. This is very important because it will enable you to do the things I've listed here, which is to coordinate activities across sectors that often go beyond health, as the previous colleague has just indicated. You saw a lot of vet activities there. That's outside health. So you need that multi-sectoral coordination. You need to communicate both to the media, the public, and share information across partners. And as I said, you need that enabling operational support in terms of materials, finances, logistics, and so on, and planning and all that. Then now let me move to the next presentation. Next slide, please. Then this is the second part. And of course, this is the traditional part which has not changed much. It's in the textbooks. We've taught it. We've operated within it, which is you have an outbreak, put together the multidisciplinary team, depending on the outbreak you're dealing with. Of course, if it is an infectious disease outbreak, certain core disciplines are fairly stable, but there are some that you adjust depending on the pathogen you're dealing with. So in my many years of teaching this, I would summarize it as CCC SLP, just to make it easier for the people I'm trying to support to understand better. And on the technical part, this is basically it. And we've already discussed this in broader detail. So I'll just summarize by saying, you need this first C, the coordination or the leadership, and that I've mentioned, the first supportive component I've talked about. Then the second C, you need your communication. And this communication has two legs, as it were. The first leg is what I've already talked about, the communication that facilitates communication with the public through press briefings, communication with the media through media briefings, communication across the partnership to make sure as stakeholders we are pulling in the same direction. Then the third C is the risk communication, which you follow later, which has broadened over time progressively to community engagement, and now it's gone beyond that to infodemic management. And then the next S is surveillance, which my colleague has presented, and then lab, and P is for prevention, which may take many forms depending on what you're dealing with. Waterborne disease, maybe water and sanitation, purely vaccine preventable, vaccination, and so on. And of course, with time, other components are coming in depending on what you're dealing with. And I won't elaborate on that. For example, we have research and innovation in the team I'm leading and a number of others. Next, please. So this is just to summarize what I've talked about. The blue part is the supportive aspect, which we lacked in the earlier decades of outbreak response. But with the recent development in global health, these systems are coming in to provide that support that makes the technical teams do their job. And the lower part, of course, is the traditional technical bits that we've always had as epidemiologists responding to outbreaks. And configurations here may change depending on what you're dealing with, and as the field develops. Next, please. Next slide.
Peter, you should be winding up.
Yeah, so basically this is my second class. So as I said before, the coordination aspect and all that part of the supportive element are these things. And I already mentioned them: infrastructure, staff, logistics, equipment, finances. Next. And that's just an illustration of what I've said already. And I think next is my last slide. Yes, so overall, you need to know where you're going. So monitor the evolution of the outbreak through the epidemiological updates, and also monitor the operational bets through the various M&E tools you may have for activities and for resource utilization. And in other diseases such as COVID, we've had things like interaction reviews and so on. So monitor where you're going and adjust accordingly. Thank you.
Thank you very much, Peter. So we are just going to move to our second last presentation in this session. And we please look into the chat room, some questions. And our second last presenter in this session is from USAID. And she is Deborah Goldstein, an infectious disease physician and a medical officer, and has been working on HIV/AIDS. She's now working on monkeypox. Over to you, Deborah.
Thanks so much, and I appreciate being included in today's presentations. Next slide, please. So these are some headlines from the international press over the last few months, and as you can see, there are strong echoes of the HIV/AIDS era in the global Mpox response. I'm going to talk briefly about some lessons learned from HIV, the use of non-stigmatizing language, a two-tier RCCE approach, and then discuss engagement with community, media, and healthcare workers, and then I'll share some resources. Next slide, please. So no one community is exclusively at risk for disease. We know that globally, most but not all Mpox cases are being detected in sexually active men who have sex with men. But we know from the HIV response that focusing exclusively on one population when an infection is emerging can propagate stigma and prematurely narrow the public health response. Pathogens do not discriminate based on identity or gender orientation. And from HIV, we know that focusing primarily on one group can create a false sense of safety among those who are not, for example, commercial sex workers or IV drug users, that they're not at risk for a disease. Stigma is based on fear of difference, and it's a barrier to health-seeking behaviors. HIV stigma, we know, negatively affects HIV testing, seeking HIV care, and the quality of care given to people living with HIV. LGBTQIA advocates are already warning that improper messaging risks branding Mpox as a gay disease, which unnecessarily stigmatizes that community. People with Mpox who experience stigma may avoid seeking care due to fear of rejection, social isolation, or the impact on their families and friends, especially if this behavior is criminalized. And all of this will undermine our outbreak response. Long-standing systemic social and health inequities fueled the HIV epidemic. With Mpox, the global community must work to avoid perpetuating these health inequities and to ensure that messaging, diagnostics, and treatment reach those most affected. But this is easier said than done. And we know that given the scarcity of global vaccines, this is hard to operationalize. We've seen derogatory words used to describe people living with HIV, even a reluctance to mention the name AIDS when someone is sick. WHO, as Dr. Lewis mentioned, recently renamed Mpox as Clade 1 and Clade 2 to reduce the stigma associating this disease with Africa. Experts are also using Mpox instead of monkeypox to reduce this association, and efforts to rename monkeypox itself are ongoing. Much as HIV was originally stigmatized as a disease of sexually promiscuous people or sex workers, UNAIDS has expressed concern that European and North American media outlets were using stock images of dark-skinned people to depict their Mpox outbreak, prompting advocates to call for photos of other skin types to avoid this racial connotation that stigmatizes Africans. Next slide, please. In the interest of time, I'm not going to go over this terribly, except to point you to a terrific resource that I linked to at the end of this presentation from the WHO, published earlier this month. It's an RCC publication discussing, for example, non-stigmatizing language that should preferentially be used when we're talking to audiences about Mpox. It's a terrific reference and worth a look. Next slide, please. Given that Mpox is a new disease for many countries, and there's a desire, of course, to avoid stigmatizing affected populations, the risk communication approach can be two-tiered. So one tier focuses on the general population, and the second tier offers tailored support to key affected populations. It's a delicate balance in directing a public health intervention at a group at high risk without stigmatizing them. Next slide. So what this might look like is for general audiences. Next slide, please. Thank you. For general audiences, including household contacts of monkeypox cases, we discuss that monkeypox is a public health issue relevant to everyone, discuss basic information about how it spreads, and how it can be acquired. And for targeted audiences like sexually active men who have sex with men or sex workers, we want to use targeted and familiar channels to directly reach this audience, perhaps through websites or dating apps. We want to make sure that we target venues where skin-to-skin contact is likely, and we want to message across racial, ethnic, socioeconomic, and geographic backgrounds. Next slide, please. So these are 3 pillars. The first is something we definitely learned from the HIV epidemic, the importance of engaging community, working directly with affected groups and community-based organizations which are affected, discussing and educating those who are at risk because they are household contacts is also really important. Media engagement is critical to combating myths and misconceptions, like recent reports that the Mpox epidemic is somehow linked to COVID vaccinations. Using social media and community influencers is essential here. And lastly, engaging healthcare workers, not only to educate them about Mpox and how to care for people with Mpox, and also about their occupational risk of infection, of course, but also to address discrimination within healthcare settings, and to educate healthcare workers to provide discrimination-free healthcare. Reports of phlebotomists in the United States initially refusing to draw blood from persons with Mpox is an example that signals a need for more health worker education. Next slide. So these are some of those resources that I mentioned earlier, and you can check those out when you have a moment. And finally, just some acknowledgements. Thanks so much.
Thanks, Deborah, and really thanks for the interesting presentation and for keeping time. And please stay on. Let's have our final presentation. You already heard from, I can't introduce Rosamond again because she has already been introduced. Rosamond, quickly to talk through vaccines. There's so many questions in the chat room about vaccines. So it's really a nice presentation to close this webinar. So Rosamond, over to you, please.
Thanks very much, Ambrose. This is just 4 or 5 slides here, so we will be able to cover a fair bit of ground on vaccines and immunizations for monkeypox and where are we now. That's, of course, if my computer cooperates. Oh, no. Okay, now it doesn't want to. My apologies. Let me stop sharing and try again. Oh, here we go. Strange. Okay, sorry about that. Okay, so the history of vaccine development really just, this is based on smallpox vaccine, which has been around since 1796. So we're talking about almost 200 years of experience with prevention and eradication of smallpox. So we know that vaccinia virus works against orthopox viruses because WHO and every member state, every country in the world has demonstrated this. However, at the time in the 1980s, the smallpox vaccine was shown in a single study, and this is the one that everyone is quoting, to be about 85% effective in preventing monkeypox, so probably clade 1 in Democratic Republic of the Congo. So it's a very thin evidence base that we're using right now, in addition to the historical experience. However, these vaccines did cause some side effects. It's a live vaccinia. These are all live vaccinia virus vaccines. And so 40 years of research have now yielded a series of different generation vaccines, which are still labeled smallpox vaccines. They're still based on vaccinia virus, which is also an orthopox virus, which offers cross protection. And we have the 2nd generation vaccine called ACAM 2000. We have 3rd generation vaccines, MVABN, so that's the one that is being used in many countries now, and LC16, which has actually been around since 1975, but it's also a 3rd generation vaccine because these are all safer, better safety profiles. And that one has also been approved for prevention of monkeypox in Japan. So we have 2 monkeypox vaccines actually. However, these have been approved on the basis of the prior experience with smallpox and animal studies and additional safety clinical studies. So WHO is continuing to work very closely with manufacturers. For MVABN, it's a single small manufacturer. For LC16, it's been around for a while, but again, there hasn't been a lot of use for it. So for both of these products, WHO is working with manufacturers to expand production capacity and ultimately access. There are also new vaccines in development. For research, WHO is recommending some randomized controlled trials. Other proposed study designs will come to in a moment. And there's already work underway with at least these countries on this slide: Brazil, Colombia, South Africa, Democratic Republic of the Congo, and Nigeria, who are engaging in conversations on vaccine efficacy research in the outbreak setting. So the immunization guidance we have so far is based on the information I just mentioned, which is that preventive pre-exposure vaccination is recommended for persons at high risk of exposure. This includes men who have sex with men. It includes others who have multiple sexual partners. Basically, as Deb Goldstein just showed you, it's also prioritizing those most at risk over others who may be less at risk. It also may include health workers, specific health workers who may be at frontline working with monkeypox diagnosis and care, and clinical laboratory personnel working, or research laboratory personnel as well, working on monkeypox or other orthopox viruses. There may be others who are at high risk in particular settings. WHO is now producing also a public health advice for sex workers and be able to provide that as well. And so that may be another group that may be considered to be at high risk in specific settings. Post-exposure vaccination is also recommended for close contacts of cases, and this could be in the family setting, for example, or partners or other contacts. I won't go through all of this slide, but this is so you can look at it afterwards, and on the prevention and vaccination column, see the actual volumes that are available globally. But in most of these cases, the product is still available in bulk. So not only are we working with the manufacturers to increase production capacity, but also working with the manufacturers to scale up fill and finish capacity into actual vaccine vials. On the lower left, you see that 70 countries worldwide have announced procurement of vaccines. And certainly we're very concerned about the equity issues here, but we also strongly encourage countries that have not yet requested any vaccine to undertake a needs assessment in their own populations. Remember, this is not for mass vaccination. This is really just for targeted vaccination. And so for that purpose, we would need to have from each country an assessment of needs and also a request, because there's a difference between what is an expressed need, what is an actual need. So there may be that there are needs that are also not being expressed. And so expressing that request is actually also important for us at the global level to appreciate who's actually looking for product. So as I mentioned, there's a stream of work on vaccines and immunization research to demonstrate the efficacy of the vaccine against monkeypox and to demonstrate the effectiveness in field settings in the context of this outbreak with different population groups affected, different settings, different countries, different epidemiological pictures. And so these are the streams of research that are being proposed and in many cases undertaken, which is clinical efficacy and effectiveness, immunization schedule, intradermal versus subcutaneous, different types of immunization schedules, other populations, and of course, behavioral insights, acceptability of vaccines, vaccine resistance or reluctance, and different deployment strategies. So I won't go through this because I think we're very short of time, but we don't, randomized controlled trials are strongly recommended where possible, and we strongly encourage countries in the African region to engage in discussions about randomized controlled trials, because it actually may make vaccine earlier, available sooner, if it's done under a research setting or under a monitored emergency use setting. These are some designs where it could be ring vaccination, community randomized trials of sort of close contact or vaccination of contacts in 1 or 2 rings around the person or in a geographic ring. And the other one is generating evidence during vaccine deployment. So even where it's not possible to randomize to vaccine versus placebo, it may be possible to randomize. Everyone gets vaccine, but some get it earlier and some get it later. And you can also generate some information, outcome data and efficacy data from the difference between those who get it earlier in the course of exposure and infection and those who get it later. So that's it. I was a bit fast, but I hope it's okay.
Thank you very, very much, Rosamund. And I think we have come to the end of this session. There are so many questions in the chat room, but in the interest of time, and also knowing that we still have about close to 500 people still online, I'm going to try to restructure the Q&A from really answering questions in the. I know that all of you 6 panelists You've looked at the questions. I'm now going to ask you, look at the participants in 1 minute, and we're going to go in reverse order from the way you presented. Rosamond, if you are going to give one take-home message to the Society of AIDS in Africa and African country, what would that message be?
For me, the message for this particular webinar is that there is a lot of work being done. Everyone here is a part of that. And working together in a collaborative fashion, we will investigate the outbreak. We will provide resources for testing to countries and to communities, and provide services to those who need them most, which will be different population groups in different settings, but without stigma.
Thanks, Rosamond. And Deborah, with your experience from HIV/AIDS and your 3 pillars, community engagement, engaging the media, and workforce, what would you, in 1 minute, what would be your key message to the Society of AIDS in Africa and to WHO Afro?
Well, I think there's a lot of expertise now from HIV, from COVID, on how to address a new outbreak of disease in a non-stigmatizing way, and how to address people at higher risk and people at lower risk with different messaging, but equally important messaging. And I think it's just a question of tapping into that expertise, because the folks assembled on this webinar and in our audience have certainly been dealing with these issues for quite some time. I think it's using the tools we have and just continuing to be aware of issues of stigma and discrimination. Thanks.
Thanks, Deborah. Peter, what would be your take-home message for the participants on this webinar in 1 minute?
My take-home message from management or response to outbreak perspective would be strengthening collaboration across partners, and especially a partner like Society for AIDS that brings in a very unique perspective. Allow me to say one thing in 1 minute. I think initially the experience from AIDS was left behind. So the team dealing with COVID battled with issues that were already addressed by the AIDS program before, issue of how to interact with the MSM community and all that. So I think I wish we engaged earlier, but I think going forward is just to strengthen that collaboration and tap into that experience. Thank you.
Thank you very much, Peter. Emmanuel, your experience, you've been in Bangui for a long time. You've worked on monkeypox, you have worked on Ebola. What would you really think is the most critical piece of work that we need to do now to address monkeypox in Africa, Emmanuel?
Emmanuel, je pense que nous avons besoin en Afrique.
I believe that in Africa, we need to encourage research because there are many fields in which we do not have enough knowledge, or our knowledge is fragmented. If we are having problems in controlling monkeypox in Africa, and if we are still having problems in eradicating smallpox, people are suffering from this disease. And it's only today when countries in the north have been hit by this outbreak that we started thinking about it. So we need, now that we need to think about the emergence of this disease, reservoirs of this disease. And in Africa, if we improve research, we will understand better pathogens which are emerging, and we can anticipate these outbreaks that are coming. So this is the message, the key message that I would like to convey: encourage research in Africa.
Merci beaucoup, Emmanuel. And Henry, I saw somebody talking about Ghana coordination involving of the vet sector. In your experience with JSI, and having listened to this webinar and also the questions that are in Q&A, Henry, what is it that you think people should go away with this afternoon?
Thank you, Dr. Ambrose. I think that the key thing is to be able to listen to communities and be able to include community feedback in the response that we are putting together. I think that if we break the allyship and the relationships that we have, we're going to have problems with our response to Mpox. The other thing I will quickly add is that we should continue to collaborate across different areas, and we should ensure that there's flexibility for receptiveness and collaboration and bringing all stakeholders on board. The issue to look at monkeypox in terms of that name itself is key, and communities must work together with WHO on that. Thank you.
Thank you very much, Emmanuel. Finally, for you, Charles, you've seen people asking what is the index for contact tracing. How, in 1 minute, how do you think countries need to move to address monkeypox surveillance?
Thank you, Ambrose. I think countries really need to increase investment in surveillance to enhance early case detection in the formal healthcare system, but also from informal sources. That is, we are talking about event-based surveillance. We also need to put ample capacity to enhance epidemiological investigation to help us understand the dynamics of the outbreak in Africa. And lastly, we need to strengthen data analytics using the modern tools that we have to inform evidence-based actions that we take to respond to the outbreak. I think this is a summary of what we need to do in terms of surveillance. WHO is available to support and work with the countries to support all these areas. Thank you very much.
Thank you very much, my panelists. I think it has really been a very exciting session. I know we've run out of time, but I know that with this really the beginning of our collaboration with the Society of AIDS in Africa, and we hope that we'll do more webinars. Some of them are likely to be focused on specific issues. I can see emerging issues here, people asking about the clades, which are circulating at the moment. We know it's mainly been clade 2B, but in DRC, of course, is clade 1, so which means that that might be actually endemic transmission. People have also been talking about the vaccine availability, and I think we might have to have a webinar that addresses just vaccines. There is the whole notion around stigmatization, and I think Deborah's presentation really articulated these issues. So we might have another webinar that really focuses on risk communication and community engagement, because I've seen a lot of things in the chats about awareness, what do we need to do? And there are so many resource tools on risk communication and community engagement that you can access. From me here, I think this really has been a very interesting webinar, and I want to thank my colleagues at the Society of AIDS in Africa for having co-organized this webinar. I also want to thank all our panelists and our colleagues at University of New Mexico ECHO program, and our interpreters. And I now want to hand over to my colleague, Mohammed, for his final remarks. Mohammed, over to you.
Thank you very much, Ambrose. It was a very interesting webinar, and I think it has been an excellent opportunity to share knowledge on virological, clinical affection control of monkeypox, as well as immunization, and sharing experiences from some African countries. We hope that this webinar has met your expectation and needs. We will share all the presentation and available tools on monkeypox with the participant as soon as possible. Also, I would like to inform the participants that the Society of AIDS in Africa will organize a webinar on monkeypox once every quarter to share more recent knowledge and update on a progress report. And I would like to thank also WHO for this collaboration on this webinar and upcoming webinars. Finally, just an information about Society of AIDS in Africa and the next ICASA 2023. I would like to inform the public that as the government of Uganda withdraw from ICASA 2023 hosting BID, we are currently processing the assessment visit of Kenya and Zimbabwe, as Zimbabwe came the third during the pre-selection process, and announcement of ICASA 2023 host country will done officially first week of October 2022. Finally, I would like to thank all of you, Dr. Ambrose, panelists, speakers, participants, WHO, and the Society of AIDS in Africa for this great opportunity. See you soon, see you next time, and take care. Bye.
Bye-bye.
Bye-bye.
Thank you.
Thank you, everyone. Bye.
Thanks so much.
Bye, everyone. Thank you very much.
Well done. Well done.
Thanks. Bye-bye.
Thanks. Thanks so much, Lewis. Been a pleasure seeing you. Bye.
Thank you, everyone.
Thank you.
Can you please confirm when shall we close the webinar?
I think you can look. You can close.
Yeah,
Okay,
can you close
thanks.
the webinar? Thank you so much.
Yes.
Thank you. It
Thank
was
you.
a
Thank you.
very nice webinar. I would like to thank every one of you for making it such a successful webinar. Looking forward to working with you again.
Thank you.
And thank you very much for your support.
Thank you.
Thank you.